Welcome back to the deep dive. Today, we're tackling Peutz-Jeghers syndrome, or PJS.
That's right.
Think of this as your rapid revision session. We want to hit those key points, the skin spots, the polyps in the gut,
hmm
and crucially, the inheritance pattern, our goal. A really concise, high-yield overview for anyone revising PJS.
Okay, sounds good. Let's get straight to it then. Peutz-Jeghers syndrome, PJS, it's a rare genetic disorder.
Rare, okay?
Yeah, and it's really marked by two main things.
Rare.
These Hamartomatous polyps growing in the GI tract.
Hamartomatous, right.
And these very specific pigmented spots. You often see them like freckle-like spots around the lips, inside the mouth, sometimes hands and feet too.
Lips, mouth, hands, feet. Got it.
You might see them on the face, palms, soles as well. Now, the polyps themselves, initially, they're usually benign, non-cancerous.
Okay, that's good.
But this is the really critical point. There's a significant lifetime risk, maybe around 50%, of developing gastrointestinal cancer by age 60.
Wow, 50% by 60. Yeah, that's high. Makes early recognition vital, I guess.
Absolutely crucial.
So what's actually causing this? What's the genetic basis?
It's down to mutations in a specific gene, STK11. You might also see it called LKB1.
STK11 or LKB1. Okay. And what does that gene normally do?
Its job is basically to help regulate cell growth and division. It kind of keeps things in check.
Ah, okay. Is there a way to remember that?
Yeah, a little mnemonic that might help is thinking. Stop the growth of tumors with K11.
STK11. Stop tumors. Yeah, okay, like that.
Yeah,
Stop the growth of tumors with K11. And how do people actually get this mutation?
Well, it's typically inherited in an autosomal dominant pattern.
Autosomal dominant. So that means?
It means if one parent has the faulty gene, each child has a 50% chance of inheriting it.
Right, so just inheriting that one copy is enough to cause the syndrome. That's the main risk factor, though.
Exactly. That's the primary risk factor.
So take us from the faulty gene to the actual problems. How does the STK11 mutation cause the polyps and the cancer risk?
Well, when the STK11 gene isn't working properly because of the mutation, that regulation of cell growth goes a bit haywire, especially in the GI tract lining.
Okay.
This leads to the overgrowth of tissue, forming those hamartomatous polyps. They're kind of disorganized clumps of normal tissue, and they can pop up anywhere along the GI tract.
And these polyps, even if benign initially, they cause problems.
No, definitely. They can get large enough to cause blockages, particularly painful small bowel obstructions. They can also bleed, leading to anemia or noticeable GI bleeding. And of course, over time, they contribute to that significantly increased cancer risk.
Right, the blockage, the bleeding, and the cancer risk. Are there other conditions that might present similarly that we need to differentiate PJS from?
Yes, absolutely. When you're thinking about multiple GI polyps, you'd also consider things like familial adenomatous polyposis, FAP,
FAP. Okay.
and maybe hereditary mixed polyposis syndrome too. They involve polyps but have different genetic causes and sometimes different polyp types or distributions.
Good point. And how common, or rather uncommon, is PJS? You said rare, but what are the numbers roughly?
It is definitely rare. Estimates in the UK suggest somewhere between, say, 1 in 25,000 people up to maybe 1 in 300,000.
Wow, quite a range, but still firmly in the rare category.
Very much so. Important to recognize, but you won't see it every day.
So summing up the clinical features, what are the absolute classic signs?
The classic triad, if you like, is those multiple hamartomatous polyps in the gut, the characteristic pigmented spots, remember lips, mouth, hands, feet, and that increased susceptibility to certain cancers.
And symptoms patients might present with?
Could be abdominal pain, maybe episodes suggesting partial bowel obstruction, or perhaps symptoms of anemia from chronic low-level bleeding from the polyps. And don't forget to actively look for those pigmented spots during examination.
Right. So if you suspect PJS, how do you confirm it? What investigations are key?
Well, you need to see the polyps, so endoscopy, like upper GI endoscopy and colonoscopy, is vital.
To visualize them directly.
Exactly. But the definitive confirmation really comes from genetic testing to find that specific mutation in the STK11 gene.
Okay. And once it's diagnosed, what's the management approach?
Management really revolves around surveillance. Because of the cancer risk, regular endoscopic exams are crucial.
How regular?
The frequency depends on age and findings, but it's usually lifelong monitoring to check for polyp growth and, importantly, to detect any early signs of cancer.
And what about the polyps themselves?
If polyps become large, cause symptoms like bleeding or obstruction risk, or look suspicious, they need to be removed, usually endoscopically or sometimes surgically. So intervention is key.
Surveillance and intervention, and preventative strategies too, I imagine.
Yes, general cancer prevention advice and tailored screening for the specific cancers associated with PJS are part of the long-term plan.
What's the overall outlook, the prognosis for someone with PJS?
It really hinges on managing the complications. Bowel obstruction can be serious, and obviously cancer progression is the major concern impacting long-term survival.
But it sounds like proactive management can make a difference.
A huge difference. With regular monitoring and timely removal of problematic polyps or early cancers, the outcomes can be significantly improved compared to, finding things late.
Okay, so wrapping up Peutz-Jeghers syndrome, it's this rare autosomal dominant genetic disorder caused by STK11 mutations. Key features are the GI Hamartomatous polyps and those distinctive pigmented mucocutaneous spots. Polyps start benign but carry that significant risk of GI and other cancers, making lifelong surveillance absolutely essential.
That sums it up nicely.
So thinking about the lifelong nature of this condition, the need for regular, sometimes invasive procedures, what do you think are some of the broader challenges in ensuring people with PJS stick to their long-term management plans? Something for you, our listeners, to consider.
That's a really important practical point.
And for more high-yield MSRA revision resources, remember to check out pastthemsra.com and also freemsra.com.